Good evening, everyone. Today we are here for the domain introduction on bioengineering, and firstly we have Professor Sandip Banerjee with us, who is the professor in the mathematics department of IIT, and his research interests involve mathematical biology and math modeling of biological systems. We will hear from him first, and after that, we'll hear from Professor Rachit Agarwal, who is from IISc Bangalore, and he is PPI of the Drug Delivery Lab of the Center for Biosystems Science and Engineering. And his research area deals with tissue engineering and drug delivery. So first, we'll have Sandip Banerjee. Yes, sir, please go ahead.
Okay, thank you, Gaurav. So, am I sort of audible clearly?
Yes.
Yeah, good. Okay, good evening, everybody. So, I'm Sandip Banerjee. My area of research is mathematical biology. So, I will speak something about mathematical modeling that we use in biology. So, the left panel which you see are for the pure mathematicians, and the right hand side is for the experimental biologists. So I lie somewhere in between, where I use mathematical tools and data from the experiments and then try to form a model and estimate the parameters and validate the experiment. So that's what I work on. So to start a problem, you pose with a question, any biological question. For example, if you consider the recent COVID pandemic, so when it will go or how it will spread, whether there will be a third phase or not, like that. Once you have that biological question, you use some mathematical tools to formulate that problem. So in my case, it is differential equation. So once your model formulation is done, then you acquire some data. You can search the literature or you can get the data directly. Once you get that data, you use some statistical method to estimate the parameters. Because when you formulate your problem, obviously there will be some parameters. Using some statistical method, if you just estimate those parameters, you plug those values, use some numerical methods to solve the problem, and get your graph. Now, from the graph, you try to answer the question which you have posed here. If it is quite close to the actual model and the actual result which sort of match with the real life scenario, then your model is quite good and you are happy with it. If not, you go back to the drawing board, means you refine your model and you continue the process. So that's how it works. Now, as I was told that many of you are from, most of you are from the biology background, also there are engineering backgrounds. So everywhere there is some mathematical modeling involved. So the question is why you do this mathematical modeling and how does actually it help in your real life? So the answer to this question is that basically when you perform the experiment, it is quite time consuming and costly. So you perform certain experiment and you reach to a result. So once you have that, if you have a tool that can predict on the basis of the experiment perform some future result, then it will be quite time saving because that's what the simulation of the process comes, and a lot of money can be saved. So once one experiment has been performed, so you now try to model and try to mimic those results that has been seen in the experiment. And if it is somewhat close to, say, even 60 to 70%, we consider it that it's quite a good model, and then try to predict the result. So once that prediction is there, then you repeat the experiment. And if you see that those predictions are correct, then you know that your model is good. And then there are a lot other steps in an experiment that can be avoided and it can go to a final step. So that is one of the reasons why this mathematical modeling is done, and it results in the simulation of the actual process. So to start with, I will just discuss mainly two aspects. One is the one which hit us, that is the pandemic model. It is called the susceptible infected model, or in short, the SI model. If you are not familiar with the differential equation, then this side you just take as rate of change. So S is the susceptible population and I is the infected population. You can take conjunctivitis, you can take common flu. That one, so susceptible means the one who is uh, who can get the disease, and the infected one obviously who has the disease. So when the infected will be affecting the susceptible, obviously when they comes in contact with the susceptible one. Just in the case of COVID, you meet the the interaction is given by the product of the susceptible and the infected, and they are infected at a rate alpha. So you have actually two class. One is the susceptible class, another is the infected class. So from the susceptible class, everything moves to the infected class. And you have an initial condition. So initially you may have n population and only one of them are infected. If you add them, it should come to n plus 1. And this is a differential equation. Those who are familiar with it, you can solve it and you can get a result. The result is shown here. So as you can see, in the long run, as t becomes large, that is, as t goes to infinity, this st will tend to 0 and this will go to n plus 1. So the conclusion is that for large t, all the susceptibles will become infected. And if you plot it, you will be able to see that the susceptible goes to 0 with time and the infected becomes n plus 1, whatever the value of n is. So this is the very first model that was developed during the plague or the Kala Jar somewhere in 1927, and it was quite a hit because that time there was no vaccine, and it was something exactly like if one get infected in certain village, the whole village becomes infected. So this was the very first susceptible infected model. Now if you refine that model, so again another class, sorry, not another class, it is something like the assumption is changed. So it is assumed that, okay, once you are infected, there is a possibility then you again become susceptible. So which exactly happens in the case of, say, common cold. So you are susceptible, you get infected when you come in contact with another person having the cold, and then you move to the infected class. And then whether you take some medicine or sometimes it's the natural immune system which helps you to recover, and you go back to the susceptible one. So this is the one when you are coming in contact with the infected individual at a rate A, and from the susceptible you totally move to the infected class. And then from the infected class you recovered yourself, or you take some medicine and get recovered, and again you move to the susceptible class. So this is just a modification of the model. Sometimes it gives a better result depending on the situation. And if you solve that differential equation, you will get this particular result. So I want you to focus on this, that in this particular case, you're susceptible. There is always a part which is susceptible. So as I told you, you have to choose the model according to the disease. Had it been a plague, this wouldn't have worked because the moment it comes in contact, 100% they will get a plague. But whereas in case of common cold, not always that it's one person coming in contact with other is catching the cold. So there is a fraction b by a which remains susceptible, and the one which is infected, that is n plus 1 minus the susceptible. The graph also shows the same kind of behavior as the your analytical results predicts. Now, so this is another one where you have this SIR model. So these all are which has been used in our pandemic. Looks very simple, but predicts very, quite a good result. So in this particular case, what happens is that you produce another class. Get infected when you come in contact with the person who is infected, you move to the infected class. From the infected class, in the previous model, you move back to the susceptible class, but then here they are saying you are recovered, so you are now in the recovered class. So if one wants to say that, okay, from the recovered class, there is a possibility, again, you will be, become susceptible, which is fine, okay. So I will just put a minus C times R, and that C times R will go here as plus C times R. Okay, so this is the kind of graph you will expect in case of an SIR model, where you see that all the susceptible goes down, all the infected also goes down, and ultimately everybody recovers. I will skip this one. So if you add the vaccine, as you can see that if C is the fraction of the population that had been vaccinated, so we will expect that they will directly move to the recovered class and bypass the infected class, which happens in most of the cases. But there are, if you consider this COVID-19, there are people who got the virus even after the first or second shot. So expected graph is that if you are vaccinated, if you are not vaccinated, this is your infection. If you are vaccinated, your infection goes down. Okay, so this is the one which shows the mathematical modeling of hepatitis C virus. So hepatitis C, it basically affects the liver. And if you watching the video, so it's called a single-stranded RNA, which is green in color, and it is covered by this fatty envelope, which actually gives a protection to the virus, and its entry is through the blood. So as it enters your bloodstream, mainly by blood transfusion or drugs, it finds the liver cell, it enters, it replicates, and then again it comes out, and again it will be engulfed by that fatty acid and move to the another liver cell. And that's how your all liver cells gets infected, and ultimately you get what is called cirrhosis of liver. So if you want to model that, you need to know a bit background, that you have two drugs which are available. One is the interferon, another is the ribavirin. So interferon is something like which is also available in your body. At the same time, it is also produced synthetically, means as a drug. And there is a ribavirin drug, which is brand name is Copagus or Ribitol. It is also available in the market. So both of them in combination gives a good result to this particular virus. The problem is that once this virus enters in your body, it will never go. It will remain in your body, and it will be in the latent stage. It may come back, it may not come back. So that's why the research is going on. And also the medicine is very, very costly. So even this interferon and ribavirin is also quite costly, but still affordable. But the others one which is sort of available in the US, even the insurance company, they cannot, they refuse to give insurance to those kind of medicines. So that is why, research is going on this hepatitis C virus. So when you first model, obviously there will be hundreds of components there. But in the hand of the mathematical modeler, it's this sort of limitations. So we will choose mostly the most important components. So what are the components here? The components here are, this T is the liver cell, which is the uninfected liver cell. The I is the infected liver cell. V is the infectious virus, and VNI is the non-infectious virus. So why it is categorized between the infectious and the non-infectious? Because as I told you that the virus will be in your body in the latent stage, and hence the word non-infectious. And once it becomes active, it becomes infectious. This is the uninfected liver cell. So I will quickly explain the terms on the right hand side, that why this kind of terms are being taken. So the moment you put a S, that means there is a constant flow of the liver cell. So some liver cells are generating at a constant rate. Now this is the growth term. So generally, when you take a growth, whatever maybe the growth is, first is the growth is sort of exponential, and then it reaches a saturation point, something like this. If you take an exponential growth like this, that won't be much of the realistic. In case of tumor, if you take a sort of exponential growth, means the person is dying. So growth is always that it grows very fast and then it ceases and comes to a saturation point. And that kind of graph is given by this kind of function. It is called a logistic growth. So you have to choose the function, sort of properly, so that it represents the actual biological scenario that you are trying to capture. Now, whenever there is a growth, there will be a death. So this minus D1T is the death of the uninfected liver cells. Similarly, this is the death of the infected liver cell. This is the death of the infectious virus. This is the death of the non-infectious virus. Now, let me come to this most important term. So, as I told you, there are two drugs. One is interferon and another is the ribavirin. So, eta 1 and eta 2, they are the efficacies of the drug. By efficacies, I mean that when you take the drug, obviously, it's supposed to work. So, that work is, that effectiveness of the drug is called the efficacy of the drug. So eta 1 is the efficacy of the drug. Now, if you take the drug, obviously, it is not 100%, the efficacy works. A fraction of the efficacy works. So you are multiplying that efficacy by a C, which lies between 0 and 1. So that the fraction of the efficacy. Now, if it doesn't work, you subtract it from 1 and you get the non-efficacy of the drug. So this 1 minus eta C eta 1 is the non-efficacy of the drug, which is acting at a rate alpha when there is an interaction between the infectious virus and the uninfected liver cell, and this whole thing becomes infectious because of the non-efficacy of the drug. So this explains this particular term. Similarly, this is the combined effect of the drug of interferon and ribavirin. So you can always argue why I have taken eta R plus eta 1 by 2. Okay, I could have taken by 3 by 4, or in general AX1 plus BY1 by A plus B. So if I choose my A plus B as 1 and 1, it gives a simplicity to this particular model. So that's why I have taken A and B. You could make it complicated. The ultimate aim is to capture the dynamics that you see in a real life patient. So this is the efficacy of the drug, due to which your infectious virus becomes non-infectious. And this is the non-efficacy of the drug, due to which your infectious cell, they are helping in the growth of the infectious virus. So that's how the model has been done, and then you use some literature or data to estimate the parameters that you see. There are so many parameters, alpha, beta, D1, D2, D3, and so on. So once you do that, the aim is to capture the dynamics that you see in the left-hand panel. So these are the various dynamics which you see: biphasic decline, triphasic decline. So the aim is to capture this kind of dynamics with the help of this model. So the first one which you see is the interferon monotherapy. That means only interferon has been used. And if you see the graph, you can see that this is the viral load that is coming down. And one thing need to be noted that here I have taken 10 to the power 2. The reason is when there is a virus in your body, so you have a count of the virus, and for which you have to do the blood test. So the count of the virus is 100. So as I told you that this hepatitis C virus will be in your body, it cannot be removed fully. So if the count is 100 or less, then it is medically told that, okay, you are cured of that disease. So that's why this 10 to the power 2 is here. And this is the sharp decline, which is the first phase decline, followed by a second phase, and where the efficacy of the drug which I have chosen, and you get cured between, say, approximately in 23 days. If you are in conjunction with the ribavirin, then you can see that. So there is a thing here. It is that once you have taken interferon, after that, if you take ribavirin, it will not work. So you have to. So when it will work that once the efficacy of the interferon dies away a bit, then you introduce ribavirin, and only then it will work. So in this particular case, you can see with the same efficacies, you come down in 19 days. So this is another graph which shows what happens when you stop the drug. So obviously, when you stop the drug at this certain point at 14 days, obviously your viral load shoots up. And finally, there is a third phase decline, or the shoulder phase, which shows that after the first phase, there will be a phase where it will be constant, and then again the third phase design. So as I told you, the aim of this was to capture the dynamics that was seen in humans. So this model is able to capture those kind of dynamics. And now if you want some future prediction, that can be done with the help of this model. So the take-home message is that, okay, so this model is able to capture most of the dynamics that is shown in the human, and basically the biphasic decline, the triphasic decline, the shoulder phase, and so on. So sort of we are happy with this particular model. I think that's it. Yeah. So thank you. And I guess I will take the questions later.
Yes, sir. We'll save the questions for the end.
Sure.
We will now open up the floor for Dr. Rachit Agarwal.
Hello. Can you guys hear me?
Yes, sir. Yeah.
Okay, I'll just quickly share my screen. Are you able to see this?
Yes, sir. We can see your screen.
Perfect. Okay, so welcome everyone. I think I'll talk about a little bit something different than Professor Sandip was talking about. This time we are going to talk about biomaterial carriers for treatment of osteoarthritis. This is a work that we have been doing for the past 4 years, and my lab essentially focuses on use of biomaterial-based particle and tissue technologies. And currently in the lab, we are looking at essentially 2 major diseases. One is osteoarthritis and another is TB, tuberculosis. So in the TB part of things, we are looking at developing inhalable carriers that can go deep in the lungs and then deliver the antibacterials. We are also looking at alternative ways to treat TB, such as bacteriophages, especially for drug-resistant TB. So on the osteoarthritis part of things, we are looking at pro-resolution therapies, so something that can reduce the inflammation and essentially promote the clearance of inflammation, because we believe that this OA, osteoarthritis, is quite a high inflammatory disease. And in another sort of pronged approach, we are looking at treating the cells present in the cartilage, chondrocytes, as precious, and if we can remove the stress that they are feeling and enhance their survival as well as production of the matrix. On the TB side of things, we are again, as I was mentioning briefly, we are looking at various things: TB drug delivery, TB vaccines, and also developing some in vitro models of TB, especially of the hypoxic granulomas that are known to be present. Apart from that, lab does collaborate with other labs, and we also work on flu vaccines as well as developing snake venoms, snake antivenoms for this. But for today's talk, I will mostly focus on this part of the lab, which is looking at elevating cellular stress. Okay, before I go into that, I just wanted to give you some motivation of why bioengineering would be useful for any of these applications. As I understand, this is a bioengineering forum, and there are people from biotechnology background as well as people from non-bio background, from engineering sciences, engineering and other sciences. So, frankly, overall, over the past couple of decades, biologists and chemists have created a very large array of new drugs, and they're extremely potent drugs. However, such advancements have not really translated into clinical success. And a major part of that is because of our inability to efficiently deliver these drugs wherever they need to go. So we were listening about drugs for different viruses from Sandeepan, and there are other cancer drugs. So these are very potent drugs, but it's our inability to be able to deliver them to the site and not to our healthy tissues, which then leads to a lot of side effects such as hair loss and immune system weakening in cancer treatments. So that's where we think these nano and micro carriers are very useful. And really what they do is they protect the drugs from the harsh environment. So when you inject the drugs, there are things like low pH, there are things like a lot of proteases and enzymes. They also allow control and sustained release. So rather than giving a very high dose initially, which gets quickly cleared away from the system, these systems allow you to give high dose, but then only a part of the high dose comes out, which is then available to do its action. And essentially, in engineering aspect, this is what we're looking at. So if you go to a clinician and they give you a tablet and tell you to take it twice a day for 10 days, this is how the profile will look like. You eat a tablet, things will go up, maybe even reach toxic concentration, and will very quickly drop down to subtherapeutic range. And what we really want is this dotted line where you give it once and it lasts you for the whole 10 days, no problems of missing the dose or having toxicity with it. So this is sort of an ideal profile, and this is what, frankly, all drug delivery bioengineering approaches are trying to achieve. And I'll give you one such example today on the osteoarthritis. So just a little bit of background, osteoarthritis is the leading cause of pain and disability, especially among the elderly. A lot of people are infected with it, about 303.1 million in 2017, and these numbers continue to rise every year as more and more population ages. There are several risk factors. Obviously, age is a major risk factor. If you are involved in very intense activities such as defense or high intensity sports, there are chances of injuries. Obesity is very highly risked. And of course, there are some genetic factors that are also responsible for this. Current treatments are quite limited. They are majorly there to treat the symptoms, which includes pain or maybe viscosupplementation. However, they do very little to prevent the progression of the disease. So eventually, this leads to total knee replacement. So the doctors will eventually replace your joint with a metal joint. And within osteoarthritis, there is a subclass which is called post-traumatic osteoarthritis. So again, this is involved with accidents and defense or high intense activities, leads to acute joint injury, which causes some trauma. And essentially, after that trauma, there is a lot of inflammation that comes in, and it is sort of considered that this PTOA is then progresses very similar to what it does for normal OA as well. It's just that the population is much younger that gets this PTOA. Almost 12% of all OA cases are associated with this, and especially young adults are much more at a higher risk in this case. So then we sort of started looking, okay, what do we do to make a treatment that actually prevents the disease or changes the direction in which the disease is going rather than just managing pain. And what we found is this axis of this inflammation, autophagy, senescence, having a heavy role here. So autophagy is a protective mechanism in which all cells, not only cartilage, but pretty much all cells in our body, they can prevent any damaged or they can sort of recycle any damaged biomolecules that may have got damaged due to various trauma or due to mistranslation. So autophagy hence then maintains the stemness of these cells and prevents senescence, which is a very negative state in which the cells go into all kind of inflammatory state. They secrete all kinds of harmful biomolecules that then cause further damage to the surrounding joint. And it has been shown actually, and this is already in clinical trials, that if you clear these senescent cells, that can prevent these post-traumatic osteoarthritis. This has been shown in the mouse model, and currently this is undergoing clinical trials. So then we sort of looked around and we found that these two molecules, rapamycin and NDGA, as quite useful molecules. So both of these molecules target mTOR, which then activates autophagy, which then prevents this buildup of all these damaged molecules, oxidative stress, and eventually then prevents senescence. So this clinical trial I was talking about, they directly target the senescent cells. What we are looking at is sort of preventing the senescence by activating the autophagy, because the cells in the joint are very limited, and we don't really want them to become senescent and then kill them. So why not catch them early? And NDG, of course, also has other mechanisms. It is also a very active ROS scavenger. So again, it has been shown in various publications that rapamycin can actually prevent these damages in mouse models. However, these have been systemically injected, and they suffer from the same problems that I was showing in the first slide of these profiles going up and down. Very little drug actually goes to the target site, and you have to and the surrounding media. So this is something that we generated in the lab. So that we find is that within 24 hours, so this 24 hours after we injected the dye, actually the joint does not have any, but all this lymphatics is taking it to local lymph nodes. So then we sort of formulated this hypothesis. We said, okay, we have healthy cells. These healthy cells undergo some stress and trauma. And if at that stage we can come in with autophagy, then it can go back to its normal state and you have a healthy joint. Whereas if the autophagy is low, that could then result into senescence and this disease joint. So then we thought, okay, can we come up with some microparticle formulations that can further reinforce this pathway while preventing the senescence pathway. And what I'm going to present today is the work done by my grad student Kamini, very talented student, currently in her final year. So what she did is she first went to a clinical setting and got these end-stage cartilage from patients who were undergoing knee replacement. So this is one such cartilage. So you can see extensive damage, very large lesions present, and must be very painful. And what she did is she histologically analyzed it. And so she analyzed for 3 markers here. This is P16, which is a senescence marker, autophagy marker, which is LC3B, and a ROS stress marker, which is 15 logs. And what you find is the autophagy is very, very high in places which are healthier, versus in the lesion area, you find autophagy is low, and vice versa for senescence and ROS, suggesting that these are actually important biomarkers, and these are something that can be targeted if we want to improve the joint health. So we then formulated our particles. We used a polymer-based approach. We synthesized particles using PLGA, very, very widely used polymer. Also has been used in humans for various other disease conditions. So we decided to make them 1 micron because some of the previous data from my lab suggested that 1 micron resides in the knee joint for quite a long duration. And we then encapsulated various drugs. So I'm showing it for rapamycin, but we got the same results for NDGA, where we can tune the release profile by just changing and engineering the molecular weight that we are using, the ratios of lactic and glycolic acid that is present in this polymer. So you can get as quick release as 2 days, you can get a moderate release in 30 days, or you can have it all the way up to 120 days or 6 months even if needed. Then we tested these particles. So we first looked whether it actually induces autophagy. And so this is a LC3B staining, and you see very nice punctures of LC3B if autophagy is active. So we do find if we give free drug as well as the particle in a cell culture dish, we find that both of them work quite well. So our drug is actually potent inside these microparticles. Similar results were again obtained for NDGA. We then looked at, okay, is it preventing senescence at a cellular level? So we then stress the cells with 2 stress agents, so oxidative stress with H2O2 and genotoxic stress with BRDU. And again, we find that, so these are pictures which can quantify. So the stress cells will start turning blue under acid beta gal staining. And what we do find is both the free drug as well as particle encapsulated drug prevented senescence. So this is untreated, very low level of senescence. With oxidative stress, it goes up, and it again comes down if you co-treat with these particles. And same, again, very similar results for NDGA as well. Next, we did an experiment to see if the chondrocytes can actually produce ECM, because essentially that's what it is. The cartilage is an ECM of chondrocytes. So there we are seeing whether they can actually produce the cartilage containing molecules, the ECM molecules there. And so this is a classical assay called micromass assay, where you seed them and you start seeing these white pellets being formed, which is the ECM that is being secreted. And again, we find that if you are treating with H2O2, the amount of the ECM produced goes down. Whereas if you treat it with these 2 free or the particle with rapamycin, you can restore the production of these ECM molecules. And again, very similar result with NDGA. Throughout the whole presentation, I'll keep switching between rapamycin and NDGA. Both of them have worked remarkably well. Next, we again looked at whether NDGA, since I showed before, NDGA also is a ROS quencher. So we look, can it block the activity of this 15 LOX, which results in a lot of these inflammatory molecules being produced. And lo and behold, we again find that both the free NDGA and the NMP, which is the NDGA microparticle, resulted in a reduction of these ROS products in the cell lysate. So we were very excited with all this data. We said, okay, let's try it in vivo. Let's try it in a mouse model. And so first we decided to see how we can do this in a mouse model. So we did an intra-articular injection to see how long they are residing in the knee joint. Do we get that profile of constant presence in the joint and sustained release, like I was showing you in my couple of slides earlier? And so this is what we found. We found, so this is the mouse knee, which is injected with free dye. So you see with the free dye is gone within 3 days. Whereas if we inject with them with microparticles containing this dye, we get the signal all the way even up to 35 days. And this has been quantified here. So very excited with this data then. Okay, then it looks like that our particles will reside for a long duration and then slowly degrade and release whatever they're carrying, in this case, the dye. So then we adopted a PTOA model of this surgery. And what we did is we had this sham surgery, which means that we open the animal, but we do not transect any ligament. Whereas a DMM surgery in which we transect a medial meniscus ligament, and this can then be stained and then quantified using ORC score, a very standard score. And higher the ORC score, it suggests there is more damage. So as you can see, there is a lesion here and reduced staining of the red, which is the cartilage region. And so we designed a prophylactic regimen. So we wanted to see if, let's say, somebody gets injured, can we then inject it within a week of that injury and give a couple of booster doses and see after 60 days in the animal whether the disease is being stopped or not. And it actually worked very well. So these are images. You can see very smooth surface with particles. The free drug does a little bit, but not really as much as RMP, which is the rapamycin microparticles. Similar to the sham animals, and this is again quantified. Only the RMP group showed a significant difference. The weight of the animals were quite good, so this was not causing any systemic toxicity to the animal. Next, we said, okay, let's challenge ourselves. Let's see if we can give it much later. So almost 24 days later, when the damage has already occurred, can it then prevent any further damage? And again, that's what we find. So again, with the RMP treatment, we find that even when it's given much later after the injury, we are able to prevent this damage. The ORC score is low, and again, the weight of the animals is not affected. We did the same experiments with the NDG microparticle. Again, looking at the therapeutic regimen this time. And again, we do find very, very similar results where you see quite a lot of reduction with the NMP particle, which is NDG microparticle, with, again, all the weights being quite similar. And then we also did it, analyze it through histologically. And again, we do find that P16, which is a senescence marker, is much lower in NMP. And it's a similar results with for RMP. I'm not showing that data. LC3 marker was up when it's given. So autophagy has been upregulated. Senescence is much lower, as well as 15 LOX, which is the oxidative stress enzymes, are also lower. And this has been further quantified. So in conclusion, I just wanted to sort of finish now saying that the biomaterial assisted sustained release of these small molecules can be quite effective. There are relevance to human findings. We've been using primary chondrocytes and tissue derived from the human patients. And then it also provides new insights of how you can prevent senescence, not only just kill senescent cells via autophagy activation. In future, we are looking to evaluate in obese mice. Again, obesity is heavily linked with osteoarthritis. And also trying to see a long-term testing of these formulations, maybe put in growth factors to see if we can even repair it and translate it to the large animal models. So I'll just quickly take 2 more minutes. I'll just finish with acknowledgement. A lot of work went in. This is the group picture. And of course, our funding sources. But apart from that, I'll just take 2 minutes. I know there's a lot of undergraduates here. So if you're interested in research, our department will be happy to interview you, happy to host you. It's a very active department, BSSE, Biosystem Science and Engineering. We have already graduated 9 students, and they have been at various fantastic places such as Harvard, Tufts, and even faculty at IIT Goa. And again, you're welcome to come and join my group as well. We are always looking for excellent and talented students. So we have positions such as PhDs, project assistants, and postdocs. So do write to me if you're interested. Okay, I'll stop here, and I think we'll take questions now.
Thank you, sir. That was a very presentation. I would like to thank you both for the presentation. It's very, very interesting. And we have a couple of questions. I will start off with Professor Banerjee's. One question that we got was when you were showing us the graph about how you find out the disease model of viruses. We had a lot of different variables there.
Gaurav, not very clear, the audio.
Oh, I'm so sorry.
So you're talking about some basic, how do I find the basic model, something like that?
Hello, this is better?
Yeah, this is better.
Okay. Yeah, so one of the questions was, how do you exactly choose which variables you want to keep in the model, and what do you discard as something that is not in the scope of the model?
Okay, so basically, if you consider this hepatitis C virus, so virus is the main component. So that is one thing. And what it is affecting the liver cells. So that is the second thing. So these two has to be there. And now the drugs coming. But then there can be other, other components that may, affect the dynamics of the model. But the whole idea is that if you keep the model simple, and if your simple model is able to capture most of the dynamics that you see in a real life patient, then it is fine. If not, then go back to the drawing board, add another component, and that's how you refine the model and come as close as to the real life situation. So start with some basic important state variables. And then if it doesn't capture the actual dynamics, then you go back and then you keep on adding. So we just don't make it first a complicated model. We start with a simple model and we stop where we find that it is capturing most of the dynamics.
Yeah, thank you, sir. One more question we had for Dr. Agarwal is the microvesicles that we have, can they also house some sort of bacterial system or something like that when we are thinking about drugs? Because a lot of our products or a lot of the things that we deal with as an iGEM club is the use of bacterial systems. So is it possible for us to encapsulate certain bacterial systems in that as well?
Yeah, no, that's a good question. So it depends. The particles that we are using, that will not be possible, but there are other sort of particles, more vesicular, more hydrogel sort of particles. These are the particles that I was describing are more sort of nanoprecipitation, microprecipitation type of particles. So they don't have much pore size. So bacteria, even if it goes there, won't be able to get its nutrient and secrete things. But there are hydrogel systems that we also work with. Some of those systems could be quite useful for encapsulation of bacteria and even delivery if required.
Right. Coming into a more general question that I would kind of like to open up to both of you. In our university, we do have biological sciences as one of the courses, and we are allowed to choose a different major as well, which will take into account engineering. So in our university, we like to foster a lot of interdisciplinary research. And since the both of you work at this cusp, could you give us some advice on how to get into that field? Because that is something that, especially in Indian colleges, what we usually see is classical biology and all that stuff. So we would like to know your thoughts on how to get into like a more interdisciplinary area of science.
Professor Banerjee, want to go first?
Yeah, no, you start.
Okay. No, I think that's a very good question, Gaurav. Yeah, I think definitely explore. I think at the UG stage, you have a very good platform and flexibility to take all kinds of courses, given you have options of taking so many electives. So definitely explore what you can, what interests you. Don't worry too much about whether I want to go into this field. Try taking a couple of courses, see if that interests you. And of course, if it does, then you can look into it. There are now, with this pandemic, actually, there are some silver linings. There are so many things that are online. There are all kinds of free online conferences, free online symposium, a lot of courses on NPTEL. Actually, I have a course on NPTEL. So there are several different things that are available that can help you explore your interest as well as build up your CV as well as knowledge before you want to go into that field, that, okay, this is the right field for me. And obviously organizing these seminars, attending a lot of seminars help quite a bit in giving the exposure of what is going on in different areas, for sure. Of course, I'm from interdisciplinary field, so I'm quite biased that this is the future, but of course, everybody should look to see if that interests them. Professor Banerjee, please feel free to.
Yeah, so whatever Rachit has told is exactly fine, but I have so I will just want to say that see, not everybody want to do the research. So most in IIT, mostly they go for jobs first. But if you want to do the research, the liking of this particular topic or a particular subject is very essential. uh, recent days, actually, biology is the hot field. And interdisciplinary, most of the interdisciplinary research is revolved around biology. There are two things there because obviously, the government put more funding there. That is number one. And also we actually need. So around say 20 years back, it is something like there is a negative correlation between maths and biology. So when I was in school, it is something like we always get a problem when we do this statistics correlation calculation, that some data is given where some one person is good in maths, obviously is bad in biology. So those sort of things is not applicable now. So basically what you will see is that in various interdisciplinary course, you will find mainly the tools that you may need in solving your biological problems. Okay, we all do that. In my case, it is differential equation. In somebody's case, it may be some statistical tools and so on. So as Rachit has also told, and I'm also saying the same thing, the thing is that you need to, like one particular, area, and that will come naturally. Okay, at this time, if you say, okay, I will do, say, tumor or cancer, you may find that, like Rachit, you find arthritis more, challenging and more, you liking in your nature. So something like that. So the take-home message is go on continuing the course, and at one point you will get the call. You will see that whether you want to go to the job first or whether you want to go to the research. So if the students want to go to their research, the only take-home, the one thing you need to know is that the topic has to be in your liking. That is the most important thing. Because after some years, if you say somebody may choose a very good institute, whereas the topic which he gets may not be that liking. But somebody may choose maybe not that good institute, but the topic is in your liking, then obviously I am sure that he or she will sign in that. Not so that's the thing.
Thanks a lot. One more thing that we wanted to know from the both of you is, since again you guys are working in this interdisciplinary field, do you see any? I'm sure Professor has seen a lot of industrial interest in this field. Dr. Banerjee, if you could also tell us if there are any industrial applications of math modeling.
Yeah, there is very much actually, but so the fact is, industry wants results. Okay, so sometimes it is not possible for us academicians to, provide the result they desire. So frankly speaking, for industry, they will invest say 1 crore, but they want the result. There will be a time frame. They want, they have their, and their problem is actually what is happening in the field. It is not some, not all research problems actually belong to the field. So that is one, drawback, which I will say as far as in Indian scenario is concerned. So if you want to be in their, the research field, which will help the industry. So most of the industry has their research division. So they generally hire there. And so they want that 100% totally dedicated in their particular area or in their particular problem. For people like us, we also concentrate on the, the teaching part. Then there is other PhD students and so on. We cannot give 100% to the industry. So that is one limitations actually we have.
Yeah,
I have in my area kind of thing.
Yeah, in addition, I would say that I agree with Professor Banerjee here that, of course, the biosector also involves quite a lot of, especially for experimental biosetup, the infrastructure requirement is quite high. So the startups are really not as easy to do as maybe, let's say, computer science or something. But having said that, at least over the last 5 years that I have been around in Bangalore area, we are seeing a lot of interest from the industries. There are a couple of consultancy projects that come in. So they would come in with very specific, like Dr. Banerjee said, they want results. So they'll come in with very specific projects, and they will just want some little part to be done, which their facilities may not allow. Other than that, at least on a research scale, there are jobs as well. There are 3 of my postdocs have gone to various different industries, Novo Nordisk, some large pharma company, or a startup as well. Atenporas was one place where one of my postdocs has recently joined. So there is interest, but right after UG, actually, I'm not sure if in the bioexperimental field, there'll be high pay scales and a lot of jobs at this stage.
Right. One last question that we got is about how or what you think is the new or the next frontier in the Indian scene when it comes to biotechnology. What is the barrier we need to cross in order to get to like the next level?
Yeah, this one, Rachit, your question.
Yeah, no, this field is extremely exciting. I mean, as Professor Banerjee sort of alluded to, this is the bioengineering era that is coming up. We have had a lot of advancements in chemistry and physics over the past 2 centuries. This is biology era because now we are starting to understand. We have very, very sensitive tools to sort of tease apart very minute and very large scale data. I mean, you have mass spec, you have sequencing going on. So you will start to see a lot of biological advancement. CRISPR-Cas is one of them. So frankly speaking, I think a lot of this will come in. And if you ask me specifically, I would say that bioengineering, since I am quite aware of this area, how you deliver drugs very well, how do you synthesize more and more sensitive imaging modalities to detect faster and at a very early stage diseases such as cancer. How do you deliver specifically to the site, something that I gave an example today. The other is how do you modify genomes? Can you correct disease, especially genetic diseases such as cystic fibrosis or muscular dystrophy? So there's a lot of scope actually, and we are just scratching the surface at this moment, especially in the bio area. I expect this field to explode and be very exciting over the next 20-25 years.
Yeah, I just want to add one thing that Rachit has told. So basically what is happening is most of departments here, say physics or chemistry, so when they're writing this project, they are involving some sort of biological problems. First is, as I told you, government is spending a lot of money, so a lot of funding is there. But also they have seen that their expertise can be used well, and also will be appreciated if some sort of biological problems are getting involved. So you get a real life scenario. Like one of my colleagues, as Rachit has told, so he has a molecule which will explode at certain point through emission of light. So he is now planning for some drug delivery kind of thing where this may work. So he is a physics guy. So that's how I think the scenarios are. So as Rachit has told, in the next 10-20 years, it's going to be really good and challenging.
Okay, I think that's all the questions I had now. If we have any more, we will definitely mail you the questions that we had.
Sure.
And I think that draws us to the end of this session. So I think the live stream can be closed right now. See, just let me know when that is.
Yeah, thank you everyone. I think it was a very nice interactive session.
Nice meeting you.
Yeah,